Welcome to A Sound Constitution on 101.7 CHLY Radio.
A health promotion show brought to you by VIU nursing students.
Over the next hour, we will be demystifying health issues.
Thanks for tuning in.
Hello and welcome to today's show of A Sound Constitution. Today we'll be talking about how homelessness and poverty can affect a person's health, as well as their access to health care.
So we have universal healthcare in Canada. Doesn't that mean that everyone gets covered for their health needs no matter what?
Well, in theory, yes, you're right. With the healthcare system that we have, no Canadians are denied healthcare. However, there are a lot of things that can play into one's ability to get access to the healthcare services that they may need.
Like what kind of stuff?
Well, like I said before, every Canadian has their healthcare covered through our universal healthcare coverage, but it's important to distinguish between what you might call health insurance, the cost of care, and healthcare delivery, how healthcare services get distributed. For those of us who are impoverished or who are homeless, getting access to healthcare, paid or not, can be a real challenge. Some people may not have the ability to get transportation to a clinic or a doctor's office, so they need to have care that can meet them where they're at. Not having a family doctor can be a big factor in access to healthcare as well. If you don't have a family doctor, you might have to go to walk-in clinics that have inconvenient times being open and also long waits. Some people might not know when it's important to go see a doctor about their health concerns, so things might get missed and aren't addressed until they're a real problem. Due to stigma that some marginalized groups may face, one or more bad experiences with healthcare professionals might make some people not seek out healthcare services even when there's a big problem. Not having a fixed address can also make accessing healthcare services a real challenge. It's also worth mentioning that there's not universal coverage for dental care, medications, or vision care in Canada. Not having proper identification can also be a barrier for people accessing healthcare. One study found that 7% of homeless people living in Toronto were denied healthcare at least once because they lacked health services card.
There are a lot of barriers to receiving quality care, hey? And so many aspects that we forget to consider, like the stigma that they may face in emergency rooms that may prevent them from continuing to seek help, or the lack of education around the resources that are available to them.
Totally. I mean, think about all the things that we take for granted. Many of us have the time and flexibility in our schedules to be able to make a visit to the doctor's office, but some people might not be able to afford taking the time off of work to go see a doctor, as most clinics are only open during normal workday hours. Or if you don't have access to proper transportation, it could be really difficult to get to a doctor's office to begin with. But then you might have to go somewhere else even to get a prescription filled.
So Jade, can you tell me about any studies that have been done to see how homelessness can affect access to healthcare?
Yeah, one study published in the American Journal of Public Health looked at unmet needs for healthcare among homeless people in Toronto. They surveyed a sample of 1,169 homeless people at shelters and meal programs and asked them if within the last year they had needed healthcare but been unable to get it. They found that about 1 in 6, or 17%, had unmet healthcare needs in the past year. They also found that mothers and children living in shelters were about twice as likely to have unmet need than other mothers and children living in Toronto.
Although homelessness is a problem for a lot of cities across Canada and the world, we chose this topic because of Nanaimo's growing homeless population. Here are some statistics that show the need in our city. According to the Homeless Hub, 174 people are experiencing absolute homelessness in Nanaimo as of 2016, with 115 of them being on the streets. It is estimated that 137 to 567 are living in hidden homelessness. As of 2015, the average cost of rent for a one-bedroom apartment was $723 per month. However, the average income assistance for a single individual is $610. So with numbers like these, it's no wonder that homelessness is a growing problem in the Nanaimo area.
Now for a song interlude, this is Current Swell, a band from Victoria, with their song Shelter.
It's so cold that I could barely even hold my own cup of coffee. It's no fair, I don't really care if you come around here now just to mock me. It's not a big deal, some consider this a steal. All in good form, just trying to keep you warm with the shelter of my arm wrapped around your back with a fake acting yawn that made you wanna laugh. All in good form, yeah. Trying to keep you warm, just trying to keep you warm with the shelter of my arm, yeah. Shelter of my arm, with the shelter of my arm. On a good ball, yeah. world, 100 more to choose. Got a heart of gold and a belly full of booze, and a rocket till he's old like I did in his youth. And do just what is told unless it's told just what to do. Cause we don't care, and we tell you why. Self-made millionaires throwing everything in the sky. We tell you why. Oh, we tell you why. All in good fun, yeah, yeah, yeah. Trying to keep you warm, just trying to keep you warm. With the shelter of my arm, yeah, yeah, yeah. Shelter of my arm, with the shelter of my arm. All in good fun, yeah, yeah, yeah. Just trying to keep you warm, just trying to keep you warm. With the shelter of my arm, yeah, yeah, yeah. With the shelter of my arm, the shelter of my arm, shelter of my arm. So cold that I could barely even hold my own cup of coffee. It's no fair, I don't really care. You come around here now just to mock me. It's not a big deal, some consider this a steal. On a good phone, just trying to keep you warm with the shelter of my arm. Tied around your back with a fake acting yawn that made you wanna laugh. On a good phone, yeah, yeah, yeah. Trying to keep you warm, just trying to keep you warm. With the shelter of my arm, yeah, yeah. The shelter of my arm, the shelter of my arm. On a good phone, yeah, yeah, yeah. Just trying to keep you warm, just trying to keep you warm. With the shelter of my arm, yeah, yeah, yeah. The shelter of my arm, with the shelter of my arm, oh yeah.
If you're just tuning in, this is the Sound Constitution on 101.7 CHLY Radio. We just listened to Shelter, a song from a local band, Current Swell.
Hey you!
Who, me?
Yeah, you! We want to hear what you have to say because
Your opinion matters!
Welcome to Your Opinion Matters. This week we hit the streets and spoke to individuals, both experiencing the effects of homelessness and those who are not, to hear their thoughts on healthcare and poverty.
Do you feel that there's a disparity in healthcare services between the homeless and the general population?
Yeah, I would say so.
Do you want to expand on that?
It might be harder for a homeless person to find the transportation to access health services, or if they don't have the proper health insurance, maybe, all sorts of things like that.
That's great. And do you think that healthcare services should maybe be reallocated to better meet the needs of the homeless?
Yeah, maybe if there was something that could travel to them, maybe to help them out more, or something that's in more central area for homeless people to access.
Okay. Do you feel that there's a disparity in healthcare services between the homeless and general population?
Yes, I do, yeah. It's a pretty big problem that I've seen.
And do you think that healthcare services should be reallocated to better meet the needs of the homeless?
I do. I think that they're doing a good job with the safe injection sites with the fentanyl crisis in especially downtown Vancouver, downtown Nanaimo. So I think that's a really good step forward, but obviously there are still needs that need to be met for the homeless population.
Do you think that healthcare services should be reallocated so that they better meet the needs of the homeless?
I do not think that they should be reallocated. I think that it shouldn't be the responsibility of the healthcare service providers to take care of this problem, because I believe that it's bigger than them and beyond what they're able to overcome.
That's
So do you
my
have-
question. I will tell you no lie.
Yeah. So, have you had any experiences, any negative experiences with healthcare yourself?
I have, yeah.
Mm-hmm.
At that hospital.
At the hospital in town here?
Yeah.
Yeah.
I was stabbed close to the heart, and they just neglected me. They just left me on a gurney for 4 hours.
Yeah.
Not good.
Do you think there's anything the healthcare system could do to improve your access?
Well, we've got access,
Right.
but it's the healthcare that's provided which is wrong. I don't know what's going on out there. I actually know it rolls downhill,
Yeah.
and it doesn't come to us. We're at the bottom of the hill.
So you feel like there's maybe discrimination against you guys a little bit?
There is, and there's neglect.
Neglect, yeah.
So do you think maybe, what could we do as healthcare providers to help make your healthcare experiences better?
Please recognize us as sick people who need help.
Mm-hmm. Just treat
That's
you
about all it. Treat me like a frickin' human.
Yeah, for
That'd be
sure.
cool.
Until next time, thanks for your opinion.
Hello, listeners. If you're just tuning in, you're listening to A Sound Constitution, and today our show is about poverty and healthcare.
Hey, so we've talked about how homelessness can affect people's access to healthcare, but how does it affect people's health?
Well, homelessness and poverty can definitely have some wide-ranging effects on people's health. Some common conditions in homeless adults include chronic obstructive pulmonary disease, COPD, arthritis and other musculoskeletal conditions, respiratory tract infections, and high blood pressure. Some people who cannot afford cigarettes may take out tobacco from partially smoked cigarette butts that are left on the street and use them to make a new cigarette. The problem with this is that concentrations of tar and other dangerous chemicals are higher and much more concentrated than you would typically find in tobacco. This, in part, can put people at an increased risk for lung diseases.
Foot and skin problems are also more prevalent in the homeless population. Repetitive walking or standing and frequent exposure to moisture are contributing factors. Early detection of problems, adequate education regarding foot hygiene, and having proper shoes and socks are ways to promote good foot care. Tuberculosis, or TB, is another health issue for homeless people. Certain shelter conditions, such as overcrowding, large transient populations, and inadequate ventilation can be favorable to the spread of TB. A study examining rates of TB in the homeless in Toronto found that they were about 10 times higher than for those of the general population. Once diagnosed with conditions such as TB, their lack of ability to keep up with treatment can affect healing and can lead to relapse.
Trauma caused by violence is also a persistent threat to homeless people. A survey in Toronto found that 40% of homeless individuals had been assaulted in the past year.
Mythbusters!
Welcome to Mythbusters, the segment of the show where we will address some common misconceptions around the topic of poverty. So, Julia, poverty is a choice. Can't people living in poverty just get a job?
Well, Sophia, there are a lot of barriers that make escaping poverty difficult, if not impossible, for many. Personal choice does play a role in all of our lives, and some people do make poor decisions that contribute to future problems. However, there are also a lot of barriers that perpetuate a cycle of poverty. Many individuals living in poverty experience difficulty retaining stable employment due to challenges such as mental health issues and addictions that inhibit their success. With Canada's unemployment rate being 6.8%, finding a job is often easier said than done. Well, Sophia, there's no real link between poverty and health.
Actually, people living in poverty are more likely to get sick, and their illnesses are more likely to become serious. They have a higher rate of chronic diseases such as diabetes and heart disease. Without a decent income, some people are unable to afford healthy foods and maintain a healthy lifestyle. They also can't afford healthcare programs, services, prescription medications, and other treatments that many of us take for granted, such as dental care. The poorest 20% of Canadians, when compared with the richest 20%, have more than double the rate of diabetes and heart disease, 358% higher rate of disability, and 128% more mental and behavioral disorders. Julia, people in Canada who are living in poverty still have it pretty good.
Well, Sophia, actually, a life in poverty is extremely difficult and can rob an individual of basic human dignity. Life in poverty is far from good. According to a 2009 study of Salvation Army shelter residents, nearly half indicated that they were experiencing an ongoing health problem brought on by challenging living conditions. While many living at low income receive government assistance, research has shown that this typically doesn't cover the cost of affordable housing.
Next up is a song from Jen Grant, a Canadian folk singer-songwriter based in Halifax. She will be coming to Nanaimo on April 5th, 2017 for a show at the Queen's Hotel. Hope you enjoy the song of hers called Dreamer.
With a faint taste of cigarettes, you write a hallelujah song. And ain't it wonderful when you're feeling alright? So I tickle up your backbone. And at the break of day, you sank into a dream, you dreamer. And at the break of day, sank into a dream, you dreamer, you dreamer, you dreamer.
This is the Sound Constitution on 101.7 CHLY Radio. We just heard the song Dreamer from Jen Grant. We now turn it over to a TED Talk by Rebecca Ani. We will hear her explore the impact of basic resources, such as food and housing, on health, and how a lack of access to these resources are a root cause to many health issues. She also discusses an organization in place working to shift the healthcare model to help individuals maintain a healthy lifestyle instead of reacting to illness.
So my freshman year of college, I signed up for an internship in the housing unit at Greater Boston Legal Services. Showed up the first day ready to make coffee and photocopies, but was paired with this righteous, deeply inspired attorney named Jeff Purcell, who thrust me onto the front lines from the very first day. And over the course of 9 months, I had the chance to have dozens of conversations with low-income families in Boston who would come in presenting with housing issues, but always had an underlying health issue. So I had a client who came in about to be evicted because he hasn't paid his rent. But he hasn't paid his rent, of course, because he's paying for his HIV medication and just can't afford both. We had moms who would come in, daughter has asthma, wakes up covered in cockroaches every morning. And one of our litigation strategies was actually to send me into the home of these clients with these large glass bottles. And I would collect the cockroaches, hot glue gun them to this poster board that we bring to court for our cases. And we always won because the judges were just so grossed out. Far more effective, I have to say, than anything I later learned in law school. But over the course of these 9 months, I grew frustrated with feeling like we were intervening too far downstream in the lives of our clients, that by the time they came to us, they were already in crisis. And at the end of my freshman year of college, I read an article about the work that Dr. Barry Zuckerman was doing as chair of pediatrics at Boston Medical Center, and his first hire was a legal services attorney to represent the patients. So I called Barry, and with his blessing, in October 1995, walked into the waiting room of the pediatrics clinic at Boston Medical Center. I'll never forget the TVs played this endless reel of cartoons, and the exhaustion of mothers who had taken 2, 3, sometimes 4 buses to bring their child to the doctor was just palpable. The doctors, it seemed, never really had enough time for all the patients, try as they might, and over the course of 6 months, I would corner them in the hallway and ask them a sort of naive but fundamental question. If you had unlimited resources, what's the one thing you would give your patients? And I heard the same story again and again, a story we've heard hundreds of times since then. They said every day we have patients that come into the clinic, child has an ear infection, I prescribe antibiotics, but the real issue is there's no food at home. The real issue is that child is living with 12 other people in a 2-bedroom apartment, and I don't even ask about those issues because there's nothing I can do. I have 13 minutes with each patient. Patients are piling up in the clinic waiting room. I have no idea where the nearest food pantry is, and I don't even have any help. In that clinic, even today, there are 2 social workers for 24,000 pediatric patients, which is better than a lot of the clinics out there. So Health Leads was born of these conversations, a simple model where doctors and nurses can prescribe nutritious food, heat in the winter, and other basic resources for their patients, the same way they'd prescribe medication. Patients then take their prescriptions to our desk in the clinic waiting room, where we have a core of well-trained college student advocates who work side by side with these families to connect them out to the existing landscape of community resources. So we began with a card table in the clinic waiting room, totally lemonade stand style. But today we have 1,000 college student advocates who are working to connect nearly 9,000 patients and their families with the resources that they need to be healthy. So 18 months ago, I got this email that changed my life. And the email was from Dr. Jack Geiger, who had written to congratulate me on Health Leads and to share, as he said, a bit of historical context. In 1965, Dr. Geiger founded one of the first 2 community health centers in this country in a brutally poor area in the Mississippi Delta. And so many of his patients came in presenting with malnutrition that he began prescribing food for them. And they would take these prescriptions to the local supermarket, which would fill them and then charge the pharmacy budget of the clinic. And when the Office of Economic Opportunity in Washington, D.C., which was funding Geiger's clinic, found out about this, they were furious. And they sent this bureaucrat down to tell Geiger that he was expected to use their dollars for medical care. To which Geiger famously and logically responded, "The last time I checked my textbooks, the specific therapy for malnutrition was food." So when I got this email from Dr. Geiger, I knew I was supposed to be proud to be part of this history. But the truth is, I was devastated. Here we are 45 years after Geiger has prescribed food for his patients, and I have doctors telling me, on those issues, we practice a don't ask, don't tell policy. 45 years after Geiger, Healthleads has to reinvent the prescription for basic resources. So I have spent hours upon hours trying to make sense of this weird Groundhog Day. How is it that if for decades we had a pretty straightforward tool for keeping patients, and especially low-income patients, healthy, that we didn't use it? If we know what it takes to have a healthcare system rather than a sick care system, why don't we just do it? These questions, in my mind, are not hard because the answers are complicated. They are hard because they require that we be honest with ourselves. My belief is that it's almost too painful to articulate our aspirations for our healthcare system or even admit that we have any at all, because if we did, they would be so removed from our current reality. But that doesn't change my belief that all of us, deep inside, here in this room and across this country, share a similar set of desires. That if we are honest with ourselves and listen quietly, that we all harbor one fiercely held aspiration for our health care, that it keep us healthy. This aspiration that our health care keep us healthy is an enormously powerful one. And the way I think about this is that healthcare is like any other system. It's just a set of choices that people make. What if we decided to make a different set of choices? What if we decided to take all the parts of healthcare that have drifted away from us and stand firm and say, no, these things are ours. They will be used for our purposes. They will be used to realize our aspiration. What if everything we needed to realize our aspiration for healthcare was right there in front of us, just waiting to be claimed? So that's where Healthleads began. We started with the prescription pad, a very ordinary piece of paper, and we asked not what do patients need to get healthy, antibiotics and inhaler medication, but what do patients need to be healthy, to not get sick in the first place? And we chose to use the prescription for that purpose. So just a few miles from here at Children's National Medical Center, when patients come into the doctor's office, they're asked a few questions. They're asked, are you running out of food at the end of the month? Do you have safe housing? And when the doctor begins the visit, she knows height, weight, is there food at home, is the family living in a shelter? And that not only leads to a better set of clinical choices, but the doctor can also prescribe those resources for the patient using Healthleads like any other subspecialty referral. The problem is, once you get a taste of what it's like to realize your aspiration for healthcare, you want more. So we thought, okay, if we can get individual doctors to prescribe these basic resources for their patients, could we get an entire healthcare system to shift its presumption? And we gave it a shot. So now at Harlem Hospital Center, when patients come in with an elevated body mass index, the electronic medical record automatically generates a prescription for Healthleads. And our volunteers can then work with them to connect patients to healthy food and exercise programs in their communities. We've created a presumption that if you're a patient at that hospital with an elevated BMI, the four walls of the doctor's office probably aren't going to give you everything you need to be healthy. You need more. So on the one hand, this is just a basic recoding of the electronic medical record. And on the other hand, it's a radical transformation of the electronic medical record from a static repository of diagnostic information to a health promotion tool. In the private sector, when you squeeze that kind of additional value out of a fixed cost investment, it's called a billion-dollar company. But in my world, it's called reduced obesity and diabetes. It's called health care, a system where doctors can prescribe solutions to improve health, not just manage disease. Same thing in the clinic waiting room. So every day in this country, 3 million patients pass through about 150,000 clinic waiting rooms in this country. And what do they do when they're there? They sit, they watch the goldfish in the fish tank, they read extremely old copies of Good Housekeeping magazine, but mostly we all just sit there forever waiting. How did we get here where we devote hundreds of acres and thousands of hours to waiting? What if we had a waiting room where you don't just sit when you're sick, but where you go to get healthy? If airports can become shopping malls and McDonald's can become playgrounds, surely we can reinvent the clinic waiting room. And that's what Health Leads has tried to do, to reclaim that real estate and that time and to use it as a gateway to connect patients to the resources they need to be healthy. So it's a brutal winter in the Northeast, your kid has asthma, your heat just got turned off, and of course you're in the waiting room of the ER because the cold air triggered your child's asthma. But what if instead of waiting for hours anxiously, the waiting room became the place where Health Leads turned your heat back on? And of course, all of this requires a broader workforce. But if we're creative, we already have that too. We know that our doctors and nurses and even social workers aren't enough, that the ticking minutes of healthcare are too constraining. Health just takes more time. It requires a non-clinical army of community health workers and case managers and many others. What if a small part of that next healthcare workforce were the 11 million college students in this country? Unencumbered by clinical responsibilities, unwilling to take no from an answer from those bureaucracies that tend to crush patients, and with an unparalleled ability for information retrieval honed through years of using Google. Now, lest you think it improbable that a college volunteer can make this kind of commitment, I have 2 words for you: March Madness. The average NCAA Division I men's basketball player dedicates 39 hours a week to his sport. Now, we may think that's good or bad, but either case, it's real. And Health Leads is based on the presumption that for too long, we have asked too little of our college students when it comes to real impact in vulnerable communities. College sports teams say, we're going to take dozens of hours at some field across campus at some ungodly hour of the morning, and we're going to measure your performance and your team's performance, and if you don't measure up or you don't show up, we're going to cut you off the team. But we'll make huge investments in your training and development, and we'll give you an extraordinary community of peers. And people line up out the door just for the chance to be part of it. So our feeling is, if it's good enough for the rugby team, it's good enough for health and poverty. Health Leads too recruits competitively, trains intensively, coaches professionally, demands significant time, builds a cohesive team, and measures results. A kind of Teach for America for healthcare. Now, in the top 10 cities in the US with the largest number of Medicaid patients, each of those has at least 20,000 college students. New York alone has 500,000 college students. And this isn't just a sort of short-term workforce to connect patients to basic resources. It's a next-generation healthcare leadership pipeline who have spent 2, 3, 4 years in the clinic waiting room talking to patients about their most basic health needs. And they leave with the conviction, the ability, and the efficacy to realize our most basic aspirations for healthcare. And the thing is, there's thousands of these folks already out there. So Mia Lozada is chief resident of internal medicine at UCSF Medical Center, but for 3 years as an undergraduate, she was a Health Leads volunteer in the clinic waiting room at Boston Medical Center. Mia says, when my classmates write a prescription, they think their work is done. When I write a prescription, I think, can the family read the prescription? Do they have transportation to the pharmacy? Do they have food to take with the prescription? Do they have insurance to fill the prescription? Those are the questions I learned at Health Leads, not in medical school. Now, none of these solutions, the prescription pad, the electronic medical record, the waiting room, the army of college students, are perfect. But they are ours for the taking, simple examples of the vast, underutilized healthcare resources that, if we reclaimed and redeployed, could realize our most basic aspiration of health care. So I had been at Legal Services for about 9 months when this idea of Health Leads started percolating in my mind. And I knew I had to tell Jeff Purcell, my attorney, that I needed to leave. And I was so nervous because I thought he was going to be disappointed in me for abandoning our clients for some crazy idea. And I sat down with him and I said, Jeff, I have this idea that we could mobilize college students to address patients' most basic health needs. And I'll be honest, all I wanted was for him to not be angry at me. But he said this, Rebecca, when you have a vision, you have an obligation to realize that vision. You must pursue that vision. And I have to say, I was like, whoa, that's a lot of pressure. I just wanted a blessing. I didn't want some kind of mandate. But the truth is, I've spent every waking minute nearly since then chasing that vision. I believe that we all have a vision for healthcare in this country. I believe that at the end of the day, when we measure our healthcare, it will not be by the diseases cured, but by the diseases prevented. It will not be by the excellence of our technologies or the sophistication of our specialists, but by how rarely we needed them. And most of all, I believe that when we measure healthcare, it will be not by what the system was, but by what we chose it to be. Thank you.
Thank you for listening to A Sound Constitution on 101.7 CHLY Radio. That was Rebecca Ani asking the question, what if our healthcare system kept us healthy? If you would like to listen again, visit the link on our Facebook page at A Sound Constitution. For more information about her nonprofit organization, visit healthleads.org.
Canada Without Poverty summed up just how much poverty affects our country, noting that poverty is one of the biggest burdens on the economic, healthcare, and criminal justice systems in Canada. It is challenging to know how much poverty costs Canadians precisely, although there are estimates available. In 2011, the federal government spent $19.9 billion on employment insurance benefits alone. The same year, almost $4 billion was transferred to low-income families from the federal government.
In British Columbia, the government spends about $8.1 and $9.2 billion on poverty. The World Health Organization has declared poverty to be the single largest determinant of health. We discussed earlier how poverty leads to illness. However, the opposite is also true. Illness leads to poverty by reducing household savings, overall productivity, and quality of life for individuals and families.
Estimates place the cost of poverty on the Canadian healthcare system to be $7.6 billion. Poverty and inequality are complex issues that have huge and devastating impacts on individuals and Canadian society as a whole. Systemic poverty is the root cause of many health and social problems, not to mention the economic toil. Creating lasting and meaningful plans that use a human rights framework to address poverty would be costly, but not nearly as expensive as doing nothing.
A recent inquiry in British Columbia reported that per year it would cost the province $3 to $4 billion to create and enact a poverty reduction strategy. A staggering amount until you consider that doing nothing to end poverty costs the province $8.1 to $9.2 billion every year. Enacting policies to end poverty is the best step forward legally, morally, and economically.
In the documentary Pour No More, Mary Walsh examines the struggles that many Canadians are encountering when their healthcare needs leave them unable to work. She finds that many people are finding that they are not fully covered by employment insurance or welfare, even while they can't work due to their health. Here are their stories.
Imagine the Great Depression. People lined up in soup kitchens, hobos in hobo camps, riding the rails. All these images are seared into our history. And look around today. The lineups at soup kitchens, so outrageous back in the 30s, now we see lineup at food banks. Food banks have now become established institutions in this country. We are still told that all those great gains that were made during the Great Depression and afterwards for social safety net, welfare, unemployment insurance, all of those things are still there, but they aren't. Why is it that people can't feel outraged when they see homeless in the streets today and lineups at food bank, yet they can still feel outraged when they look at an old film about the 30s and say, wasn't that awful? Well, look around. It's happening today.
We thought we were done. I mean, hadn't our parents and our grandparents fought long and hard to produce a new society, a more just society? Because after the Great Depression and the horrors of the Second World War, Canadians seem to have come together and said, never again. They wanted to build a society that was capitalist, yes, but with a human face and a helping hand. We introduced universal health care, unemployment insurance, pensions for old people, laws that made it possible for workers to form unions. We wanted to build a society that was good for everybody in the society, not just the barons of Bay Street, good for them too, but for the workers in Winnipeg also.
Several years ago, my daughter had to have a kidney transplant. I had to request time off work, so I was gone for approximately 10 weeks with no income. Then last May, I was diagnosed with breast cancer and had to have time off. And again, no pay. You have to go to work whether you're feeling ill or not, because you've got payments to do, obligations, and I mean, oh, wow. To make ends meet, I had to do it. I had to take my chemo treatments, all my doctor's appointments. I worked everything into my lunch hours, my days off. One of the things that's kept me going is my daughter. She's been here for me through all of this. I found out that I had breast cancer on the day of her 16th birthday, and that was hard, but we made it. My sisters, my mom, we were all there. We did it all together. A good chicken recipe. Her and I have been through a lot, right from the time of her kidney transplant, her doctor's appointment. My parents helped me out a great deal with bills, but someday I'll be able to be there for them as well, I hope.
We're not on welfare, no. I absolutely refuse to go back for the simple fact that the first time we went in, I got in an argument with the woman running our file because she didn't believe we needed welfare. We were there with all 4 of these, and she treated us like we were dirt. She gave us attitude. She asked him why he couldn't find a job, what was wrong with him, why I wasn't in school.
You have to understand that when you first go to the welfare department, one of the very first questions they're going to ask you is, what assets do you have? So if you say, oh, I have $5,000 in the bank, they'll say, spend it and come back. If you have a car worth more than I forget what, but of any value, they say, sell that. If you have RRSPs, you're expected to spend your RRSPs before they'll give you 10 cents. Now, and the way I see it, this is setting these people up for permanent poverty.
I just think the welfare system, the way we've constructed it, deliberately degrades people. It makes their lives miserable and harsh. We've managed as a society to turn these people into pariahs, so that social assistance is a dirty word. Previous governments have done such a good job of demonizing people whose crime is hardship.
They told him he had to do 20 different things in order to even get on welfare. It took us 2 weeks to even do everything she wanted. So I said, you know what, this time I'd rather just suffer. I'd rather starve, make sure they eat, than beg them for money again. And besides, when we get on welfare, they barely give you enough. They take half your child tax check away. And then when you do get a job, they take half your money away, so you can barely ever get off of welfare.
When people are forced to rely on social services, welfare, for example, they're facing a system which has been eroded and eroded over the last decade or so that it's simply not adequate to meet the needs of these people. The welfare workers are trapped. I believe that they have a real desire to help the people that they're working with, but they have gigantic caseloads and a mind frame in the organization that says, let's keep our costs down no matter how we do it, we have to keep our costs down.
Low-paid workers are left with no choice but to collect welfare, and they rarely get a break. Leilani Farah is a lawyer who heads the Centre for Equality Rights in Accommodation. She says that women in low-paying jobs are especially hard hit.
You take a low-income earner, single mom, 3 kids, and she misses a couple of shifts because her childcare arrangement falls apart for whatever reason. She gets fired. She can't go on employment insurance because she was fired, so she goes to welfare. Her welfare entitlement is so low, she can't pay her rent. The landlord decides to evict her. The only option for her is to go to emergency shelter. She goes to the shelter. The conditions are awful. So she starts looking for an apartment. She finds one. It's awful. Bed bugs, rodents, etc. And she's already been in the system, right? She's been in that shelter. Child welfare authorities have sort of kept track of her, and they find out she's in this lousy apartment. So what do? They take her kids.
And now for some good news.
Hello, listeners, and welcome to Good News, the segment where we talk about the exciting things happening in our community. Brianna Hebert is the volunteer lead for Nanaimo Regional General Hospital's Discharge with Dignity program, which provides supplies to patients in need being discharged from the emergency department. Here's a short clip from Shaw TV about the program.
And often it's very difficult to actually make people feel like they matter when they come in, especially the more vulnerable people in our community. You see so many people come in and they carry all their belongings in a black garbage bag. They come for treatment and you take off the shoes and their socks are falling apart. And it's really quite difficult to then send them home in that same condition.
So we create backpacks for homeless people who come into the hospital or people who just need some supplies and are lacking it. So we fill bags like for men and women and like gendered supplies, and there's like toiletries, shampoo, conditioner, soap.
Socks especially, things like chocolate bars or granola bars, porridge oats that they can just add hot water to, which will give them a quick hot meal.
Items that we think that they need, like maybe scarves, toques, mittens, those kind of things.
So the actual emergency department staff came up with the idea. Some of our staff members actually went onto the streets to speak to people that live on the streets and ask them how we can serve them better. And it's with those suggestions that they came back to our department and we fought to set up the program.
It's really grown since Brianna took the leadership of it.
All this work that you guys have done has been really amazing. We're going to get this out to the homeless people who come into the hospital, and if we have any bags left over, we'll just bring it to
Then we started looking at expanding the program and starting to look for donations in the community. So Brianna was really instrumental in making those first contacts with the schools, with different organizations in town. She spent a lot of time just creating information about the backpacks, what the Discharge with Dignity program was all about.
We actually got a lot of these. We got a 903 and our goal was 500.
Wow, you doubled.
So we almost doubled our goal, yeah.
There are some elementary schools that did a sock drive. They had a Socktober program, and they collected over 600 pairs of socks for the hospital and for the patients here.
The most important thing in the pack is our discharge leaflet. It helps people connect with those services that are out in the community that they may not actually know about. It gives them a map and locations of the different services that they can go to, different shelters.
It's been really heartwarming to see all the support from the community and all the support in the hospital for it. So it's just like been really enlightening for me to see how much like there's a need in the community and how we are able to go and make a real big change and make a big difference within the community.
To be able to give somebody a clean pair of socks and an actual bag to put their belongings into is huge.
The staff here in the emergency department at NRGH really truly care about the patients here. They go above and beyond every opportunity they can.
We set ourselves a target of 250 packs. We've given out 125. And we really do need more packs and more contents. If people want to donate, they can bring them to the emergency department, they can bring them to the information centre at the front of the hospital.
That's it for this week's Good News. Until next time.
To end today, we have a song for you from Vince Vaccaro, a musician from Victoria. This is his song, Here in My Place. Thanks for tuning in to A Sound Constitution. We'll be back next week.
circus, it's only a cage for you. Trust yourself in this moment. Your heart is the way to your truth. In this time I've been given, there's so much that I want to see. There's a light in this ocean, it gives me the strength to believe. What if I am a stranger from finding what I need the most? There's a light in this ocean, it's giving the sun in my soul. Could the long, drawn-out circles be keeping me safe from the flame that I once chased and wanted? I know not what I have escaped. What if I am a stranger to finding what I need the most? Like a fog, all my questions, a cloud and the sun of my soul. What if I am a stranger to finding what I need the most? Like a fog, all my questions, a cloud and the sun in my soul. Here I am in surrender, and trusting I don't know the way. But tonight, as the sun sets, I know that I'm here in my place. I know that I'm here in my place. I know that I'm here in my place.
Thanks for listening to A Sound Constitution on 101.7 CHLY Radio.
For more information, questions, or comments, please visit our Facebook page at A Sound Constitution.
Tune in again next Thursday morning from 10 to 11.
Stay healthy, Vancouver Island.